the Health Connector Authority meeting to order. Great to be with everyone, even if it is by Zooming. And of course, as everyone knows, we'll take all votes by roll call. As the board knows, Louis is not with us today. Louis is out on a personal leave, and we look forward to welcoming him back soon. As of course, the extraordinary staff of the connector are ensuring everything is running extraordinarily smoothly. Grateful to Audrey and the team that will lead us through today's agenda. We will not have an executive director's report today and go straight into the heart of our meeting, which starts with the ongoing preparation for the end of the federal public health emergency, whenever that may occur. And we can talk about that a bit. We'll see who's, can project it the best. I have my own thoughts about that. We'll go that, and it's important for all of us to see how closely the connector and Mass Health are working in preparation for the end of that public health emergency. A little bit on the non-compliant health plan marketing, the federal policy update by Audrey and Marissa, of course, and then we have a vote on a contract for, I can't even pronounce it, Samartronix for the Amazon Web Services. But with that, why don't we go straight into the preparation for the end of the federal public health emergency, whenever it may occur. So I'll turn it over to, I think, Audrey, Marissa, and we are joined by Monica Sawney, who's the terrific chief of staff at Mass Health. That some of you may not know Monica.
Great, thank you, Secretary. Just see if I can get this to go into slideshow mode. Sorry about that. One moment.
Right. We see you, but not the PowerPoint.
Yes, it's giving me trouble for some reason. So let me just close and reopen it.
Marissa, if you put it into slideshow mode first, then it might be easier to show that window.
Okay, good tip.
It can be the rain effect on a PowerPoint.
Endless gremlins in PowerPoint and Zoom.
Yep.
All right, can you see that now?
Yes.
Perfect.
Thank you.
Thank you for your patience. Good morning, everyone. Today, I'm pleased to be joined by my colleague, Monica Sawney from Mass Health, to share an update on preparations underway for the eventual end of the federal public health emergency, or PHE, which will trigger the end of eligibility protections in place in Medicaid programs across the country. We'll walk through what we know about the end of the PHE and the work we're doing to prepare in close collaboration with each other. And I'll turn it over to Monica to kick us off.
Thanks, Marissa. So as the secretary said, I'm Monica Sawney. I'm the chief of staff at Mass Health, and thank you very much for having me here today. So I'm just going to talk through a little bit of the context here. You'll see on this slide, and then we'll get into some details about all the preparation we're doing on our end in conjunction with the connector. So as many of you may know, when the federal public health emergency began back in March 2020, we basically we began holding all Medicaid redeterminations. So those eligibility protections, like I said, have been in effect since March 2020, and we expect them to continue into the fall at this point, though there is the possibility that they could continue even further than that. Along the way, though, we have been continuing to process eligibility renewals in the kind of in the background in the system. That gives us a little bit of a head start on the renewal process when the public health emergency does end. And so a lot of members' eligibility has continued to be renewed as normal, either through kind of automatic data matching, where the member doesn't even have to respond, and we're able to just renew it in the background, or we reached out to the member for some more information, and they got back to us. If a member didn't respond, or they were found ineligible during the routine kind of redetermination we did, their eligibility was protected, That was, like I said, in accordance with those federal requirements. What I think is really important to drive home is that once the federal public health emergency does end, we will need to complete full renewals again for all members. So all, at the moment, 2.2 million members on our caseload, and that is within a year of the federal public health emergency ending. You can imagine that's a pretty big lift, and so that's what we'll get into some more detail on. Of course, we are very committed to minimizing gaps in coverage and supporting members during this time if they need to transition coverage. We've been, both Mass Health and the Connector have been working very closely together, and we are working with Healthcare for All on an outreach campaign to members to make sure they have the information they need for when this does begin. We've also been ramping up operations on our end and working on some system updates, that sort of thing. And also, as I said, working with the Connector closely, most importantly, to enable those smooth transitions for members if they're no longer eligible. So that's a quick overview. Mercy, you want to go to the next slide? Great. So like I said, we'll be reevaluating or redetermining all 2.2 members, 2.2 million members, to see if they are still eligible for Mass Health. Members will fall basically into two buckets. Some will auto renew, as I said, and we use all sorts of federal and state data matches to check on their coverage, income, and other information, eligibility data. And if we're able to auto renew or do an ex parte renewal, as it's sometimes referred to in the system, then that's great. The member doesn't need to do anything, and they'll just be renewed for another year. One thing we've done in the system is to expand what the variance and what a data match shows compared to what the member may have on file already, to help increase that overall auto renewal rate on our end, which is helpful for members and also helpful for us in the limiting the number of members that we need to reach out to. For those who we do see different information in the system and it is outside of that variance that I just discussed, we'll need to reach out to the member and ask them for information, whether it's income information or something else. Based on that information, we'll determine what benefit they're eligible for, whether it's Mass Health Connector or something else. And of course, in the instance where they're eligible for a Connector plan, we'll make sure that we're working closely with the Connector to get them enrolled in a plan on the market. All right, Marissa, I think we can go to the next slide. Okay, so I said we'd talk in a little more detail about all of the preparations we have underway. So I'll speak to the Mass Health side. So as I said, we will be completing all renewals over the 12-month period once the federal public health emergency ends. This will balance both the operational impacts of having to redetermine so many members kind of all in once, but also making sure that we comply with the federal requirements. You'll see that this kind of illustrative timeline that we have here assumes the public health emergency will only be extended through October. That's up in the air, but if we wanted to be able to provide some kind of grounding for this. So this is the example that we put together. And so you'll see that if that happens, we will start ramping up and be processing more renewals kind of than we would on a normal basis, because we have more members. And so we want to make sure right now our caseload is higher. And so we want to make sure that we're able to process everyone. And then as we get into the later out months, then that number will start to come down and we'll get back to kind of, regular course of business in terms of volume. I won't reiterate all of this stuff, but of course, to the extent that we're able to automatically renew somebody's eligibility, we will gladly do that. If it can't be renewed automatically and we need more information, we'll reach out to them. We're going to do this using a blue envelope. Some of you might remember from the ACA, we also, during the ACA transition many years ago at this point, we also kind of used a specific colored envelope to kind of anchor individuals to that color and did a campaign around that. So we're going to do that again to make sure people know, if you get this envelope, it's really important that you respond. And then, members have to respond to that information, obviously, so that we're able to properly redetermine their coverage. And there's many ways that can do that online, by mail, by fax, and in person. All right. Thanks, Marissa. So I would say that, Mass Health is preparing in a number of ways for this big, redetermination process. But I think you can categorize it kind of into three buckets. So one is just increasing overall capacity and our ability internally to respond to this increased renewal volume. So we're hiring additional staff, increasing our eligibility staff, so that we're able to process all the documentation and stuff that will come in, work with members directly, all those kind of important pieces. We're also expanding our vendor capacity, and especially in our call center, so we're able to answer, all the calls that we will potentially be getting from members, and make sure that we keep wait times low. Also be able to take applications over the phone and that sort of thing. One additional piece I'll mention is that we're also increasing the number of staff we have in our Board of Hearings office, so that if there are eligibility appeals, we'll be able to work through those quicker for members and sort out their eligibility without a backlog. I guess all of that is just to help get through this process as quickly and efficiently as we can. Second bucket is a lot of the kind of system changes we're making. So I mentioned that we updated or increased the variance, or what's known as reasonable compatibility, that threshold in the when we have income or something else on file for a member, and the data match comes back. So it was 10%. We've increased that to 20%, so that now if there's a variance up to 20%, we'll still count that as a data match, and we won't have to go out to the member to ask for additional documentation on their income. We're also working to do a lot of new communication with members, so using both text and email, which is not something we've really done in the past, but I thought this was the kind of perfect opportunity to begin using those communications method. Especially excited for the texting. We all know that's how many people communicate these days, and I think we think that'll go a long way to reaching out to members. So we're working with vendors on that. And then another thing that I think is really important is making sure that we have updated member contact information. So it's been over 2 years since March 2020. A lot of our members have moved, their phone numbers might have changed, all sorts of things. And so if we're not able to automatically renew their eligibility and we need to reach out to them, we want to make sure that our request is getting to the right place. And we want to make sure we have their address, we want to have their phone number, we want to have their updated email address. And so we're doing a bunch of work to make sure that we have that updated contact information for them, including working with the vendors on trying to validate and source that data, but also doing a campaign to members to get that information. I'll talk about that a little bit more in a second. But kind of segues into the last and third bucket, which is the outreach strategy to members and others. So really making sure that our members know that this is coming, and when it happens, that they know that they really need to respond if they get outreach. Like I said, for those who auto renew, that's great, and we hope that will be a large portion of our members. And it'll happen seamlessly in the background, and they won't have to do anything. But for those who do need to respond in some way, we really want to make sure that they get back to us, either so that they keep their Mass Health, or if they need to move into another plan, that we're able to help them make that transition and they don't have a gap in coverage. So I said that we're working on gathering their contact information. That's the first step here, especially while we're still waiting to see when the public health emergency will end. But then after that, we're already planning for the next phases of the communication strategy. We want this to be really equity oriented, and I'll talk about that some more on the next page, but make sure that we're targeting the communities where we have a lot of members, that we're doing that in the language that they speak, in the places that they are, the media, all that sort of stuff, and putting together toolkits and that sort of thing to target our outreach. And then obviously working really closely with all of our various partners, advocacy organizations, our providers, our health plans, community groups, and others. And this is where, Healthcare for All will play a big role as well. So I will get into some more detail on that on the next slide. Thanks. So both Mass Health and the Connector are working closely with Healthcare for All, as I said, on an outreach campaign. So we already signed a contract with Healthcare for All earlier this spring. At this point, our plan is to launch the broader outreach campaign in September, assuming, the public health emergency seems like is ending at that point. So again, timeline is illustrative at this point, but that's as of now, we're planning for a fall into the PHE. And so that's when we'll do this. Healthcare for All is going to do on the ground outreach, which is not something we have done previously for Mass Health members, but actually being out there, canvassing, tabling in the community to try to get the word out to members, to make sure that they're updating their contact information and responding to Mass Health when they receive outreach. Healthcare for All is also going to be doing grants to community groups in the targeted outreach communities that we've identified. And those community groups will go out and reach out to members directly. So it's not just, Mass Health or the Connector or Healthcare for All, but also really trying to embed ourselves within the communities where we know we have a lot of members and working with individuals there to get the word out. Healthcare for All is also going to be doing targeted media buys, as I mentioned, in multiple languages, culturally relevant messaging to reach our members where they are. In addition to that, I had said we're very excited to be starting text and email and using these new, not new in the world, but new for us methods of communicating with members. So we'll be doing a bunch of direct to member campaigns on our end and with robocalls, etc. We're also going to be asking all of our partners to really dig into this with us and make sure that we are reaching members. So all of our members in managed care plans, should be receiving outreach from the plans. We're going to ask providers to help us with this. All of the assisters we have, so both the certified application counselors on the Mass Health side and the navigators on the Health Connector side, and other stakeholders, other community groups, that sort of thing, to make sure that they're sharing these messages, helping members update contact information, and making sure that these renewals go smoothly. Another thing that we're pushing now is encouraging members to use self-service tools. So the HICS system does have a self-service portal where a member can go in and update their own contact information and complete a renewal. And so we've actually just put out in the last couple of weeks a bunch of information guiding members through that process, is how to log into the self-service portal and make those updates. And that's something that I think could be really helpful, rather than having to call customer service or something, that a member can just go online and make these updates themselves. And they'll also be able to schedule appointments at Mass Health enrollment centers if they want to come in and have in-person support directly from Mass Health on their renewal. Lastly, so I mentioned that there's particular communities we're going to target, but there's also populations that we want to make sure that we're targeting: members with disabilities, those who are homeless, those who are over 65, making sure that, those populations who, all of our members rely on Mass Health, but we know we have members who really rely on Mass Health and want to make sure that they do not have a gap in coverage. That they either keep their Mass Health or are moving to another plan if they're eligible for that, but really wanting to target some of those kind of more vulnerable population groups. So those are a few that we wanted to highlight. Great. So I think I have one last slide. Okay, so I just wanted to give show you all of you just a little bit about one of our campaigns. So I said that we're really trying to make sure members are updating their contact information. And so this is a little bit of a campaign we have right now, helping, encouraging members to update their contact information, and then, making clear that they can do this online using their HICS online account, or that they can, just as easily call customer service and make that update as well. So we kind of consider this phase one of our communication strategy, so outreach and strategy so far. So this is the work we can be doing prior to the end of the federal public health emergency. It's always good to have member contact information. So All right. And with that, I think I'll turn it over to Marissa.
Yes, thanks. I can just pause for a minute if there's any questions for Monica before I move into my section.
Yeah, Nancy.
Yeah, thank you. Thanks, Monica, for joining us. And all of this is really, really impressive preparation. It's particularly exciting to see us partnering with Health Care for All for community outreach, I think, particularly after the wonderful work they did on vaccinations over the last couple of years. Do we have any, this is not a fair question, but I'm going to ask anyway. Do we have any idea or estimates? I'm sure you must be working with some about how many people are likely to have the information to be auto processed, including after, this slide. That's my first. And I'm happy to wait until Marissa presents, I think, for a variety of reasons that are pretty apparent. It seems hard to me to believe that the federal government's going to end the public health emergency right before elections. So then that begins to push it into open enrollment, which I think would create lots of other complications. So hard for me to imagine. So just the timeline here, although completely understand why you're planning to this, like, any thoughts from anyone about where we may end up before all this goes into effect and what the implications are if it's actually 3-4 months later in terms of the planning for this?
I'm going to have Monica can sort of give you a sense of where I think how people are going to, who are going to probably prioritize on, but I would agree with you. It is difficult for me to imagine that the public health emergency would end prior to the midterms. And even if it was, say that it's November, right? The reality is it's 30 days after that. So even if it ends, you couldn't really, you'd start, but you wouldn't really be going into high gear on redeterminations till December if it was November. So, we need to do all the planning. It does obviously have, and I think when you hear from some folks, the operational, like into open enrollment, how does that impact then open enrollment? But Monica, do you want to talk a little bit about what we think? And again, this is just sort of, people doing all the prep work.
Yeah, so I don't, at least not on hand, have a specific number or percentage to share, Nancy, but I would say I think we're hopeful that it will be a decent number. I think even today we see a fair number of people who renew automatically. I think increasing that income level by 10%, we've basically doubled it, should help a fair amount. We've increased our data sources. We've tapped into new data sources that we weren't using. We've talked with other states, and so while I don't have a concrete number to share, I do think it'll be higher than it has been in the past, and I hope that's helpful.
Fair enough.
I think, Nancy, and I'll just have Michael, I think what we have, like my direction or my hovering over this has been, one, we want to ensure, as much backroom support for individuals, right? By building it, as you heard, building up the call center, contracting with Health Care for All, both the connector and Mass Health One contract, who did extraordinary work during the vaccine equity work. So it creates a good bench and a lot of learning, so we don't have to relearn that. The self portal, which is maybe intuitive for everyone, for all of us, but something really Mass Health just historically, and I think because of the history of HICS and the like, right? Really, it was like people, not having people go into the self portal. So really building that up for people for whom that is like completely a reasonable thing to do. And what Monica was really not as forthcoming about as she could have was really any other database that Mass Health can use to validate people's eligibility without the individual having to basically initiate has really been our focus of being as part of being prepared on this. So they've really expanded, I would say, the tools in the Mass Health toolkit around eligibility as we prepare for this.
And those all make total sense. And it's like 30% of the entire state's population.
Yeah,
so it's a daunting.
Yeah. It's the April point in time, Mass Health was 2.217 million people. Yeah. If you do the year-to-year comparison, it was 2.053 million in April of 2021. Yeah. So it is daunting, but
well, it means our membership will be going up at the connectors.
That's what that's what we that's what we expect, and I think that's what we're going to try to ensure, like that transition and the smoothness of the transition. Sorry, Michael, you had your hands up.
Yeah, no, glad to hear you all have that discussion. And I also want to thank Monica and Mass Health in general for all the work they're doing. And of course, later I'll thank Marissa. But nevertheless, what I'm interested in is what are any plans for grace periods or any other type of activities? There's just no way something of this scale is going to be done flawlessly, in my view. So the question about what's going to happen when people need care and may fall between the cracks, if there's grace periods or other activities that we might be able to sort of compensate if that happens.
Sure. Thanks for the question. So I need to confirm the exact timing, but I believe if a member doesn't respond to their redetermination, they do have 2 or 3 months. I just need to figure out. I need to confirm if it's 2 or 3 months, whereby if they come back into the system and they are eligible, that their coverage would go retroactively back to the date that they lost it. So there is a fair amount of grace period, and I think if somebody does fall off coverage, we'd be doing outreach in that case also. So there's a bit of time there. Does that answer your question? Is there anything else you were looking for?
No, that was perfect. Thank you.
Sure.
Great. Well, if nothing else, I can dive into the Health Connector side of this and let you know that. So we also have a lot of plans going to help people who are going to transition to Health Connector eligibility as part of the end of the public health emergency. And we've categorized it across 3 broad areas of work. Designing clear, effective, and consistent messaging that affordable coverage is available and distributing it widely. Building capacity for volume in our operations and making coverage easier to get and keep for those who qualify. In terms of messaging, we've heard from some national sources that general awareness of marketplaces is something that needs frequent refreshing. And while it's possible that there's a higher rate of brand awareness in Massachusetts, we do want to make sure that people are aware of who we are and what we offer, particularly if they joined Mass Health during the PHE and haven't been our members before. To make sure our messaging is effective, we're engaging in focus groups in 5 languages right now to test various approaches. And we'll use this foundational research to create both a variety of materials for our own use, as well as a toolkit that our stakeholders can use in their interactions with individuals, ensuring a data-driven and consistent approach from all sources and in a number of languages. The second, we're preparing to see increased volume in transactions of all kinds. System-wise, we've supported Mass Health's development of functionality to support members, assisters in the agency in managing renewals. Operationally, our call center is prepared to ramp up hiring, is adding chat and chatbot tools to its repertoire this month, and is looking at the ability to interact with individuals via text message as well. And finally, here I'd note that we gathered information from Navigator grant applicants on plans for how they would support members at the end of the PHE, and we'll follow that up with training and support for consumer assistance in conjunction with Mass Health. And lastly, we're looking at ways to make the process of qualifying for and enrolling in Health Connector coverage as easy as possible. So we've talked about a few of these items with you before, but we can share that the auto enrollment process we noted at our last meeting went live in April, and it's enrolled over 400 individuals for May and June coverage. And as a reminder, these are individuals who checked a box on their application authorizing the Health Connector to enroll them if they qualify for $0 connector care coverage and don't choose a plan for themselves. Similar to what Monica mentioned with that expansion of the allowable variance between what's on an application and what our data source says, that's extra variance that is at play for Health Connector membership as well. So we're hoping to kind of reduce the number of people who need to send in income verifications, but we will be providing new templates for them if they do need to send in information, because one thing we've heard over the course of the PHE is that people may have started their own businesses or had changes in their income and they're not totally sure how to document that. So we'll see what we can do to support them. And finally, we're exploring an extension of the special enrollment period for individuals losing other coverage from 60 to 120 days. This is a strategy we've heard a few other states are pursuing, and it could provide a little extra runway for people as they navigate their coverage transitions and would reduce calls by allowing for more self-service. So let me pause here and see if there's any questions.
So Michael, I think the fourth point is also another protection for individuals if we extend special enrollment period for folks for whom, getting, even if it's a nice colored envelope from us several times, just don't respond and then are determined not to be eligible for Mass Health, but then there's like this special period of open enrollment. So I think folks are really, that's why having a functional HICS system and the really strong work between Mass Health and the connector as we go through this period. Just remind folks, we did a massive redetermination in 2015 with perhaps not the best technology available to us, and that was 1.45 million people, I believe, and that was very much a heavy paper process. So I think we are in much better stead as we whenever this does occur.
So for what it's worth, my general view is do as best you can to make it all work. And I think it's clear for Monica and Marissa, we're doing that. And then put in place as best the processes you can for when it inevitably doesn't. And I guess the last thing I'll say, just for the sake of saying it, is I worry a lot about coverage. I don't want to downplay the importance of coverage. I worry more about access to care. And so the important thing is that individuals, as they go through this transition, get the care that they need, and we sort out the coverage as best we can. And that seems to be proceeding. And I think things like the special enrollment period, all the outreach, all of the simplifications, I think are the exact right type of things to do, and the extent to which we can use the new technologies, the best technologies to make that happen, partners to make that happen, all of that's better. But as Nancy pointed out, it's a ton of people, and they all have a lot of complicated different things going on in their lives besides sorting out whether they're in Mass Health or in the connector or whatever they're doing. And those other things going on in their lives can inevitably make it hard. And there's going to be a subset of people whose conditions will be changing over this period, right? So it's complicated. So
yep. I couldn't agree with you more. Got to have great plans, and then you have to have processes for when the you need to resolve the immediate issues that come up that even the best plans can't anticipate for individuals. No, couldn't agree more. All right. Other questions? And then we can all have a lottery as to when we think the public health emergency may or may end. I actually think it, we'll get through pretty much the entire calendar year in the public health emergency, but I could be wrong about that.
I thought the fall was supposed to be another uptick. I'm not sure that's true. So
I think, we're going to have surges, right? We're going to see ups and downs of the coronavirus in terms of cases and the like. So, but I think there's other things to play also in determining when the public health emergency ends. Anyway, all right. I just want to thank everybody for the extraordinary amount of work in planning. to ensure we don't have gaps in coverage and really, as Michael said, sort of gaps in care for people. So, all right. Any other comments, questions? Thanks, Nancy. Yeah. All right. All right. On to non-compliant health plan marketing. We have some of the greatest titles here. Non-compliant health plan marketing issues.
We were trying to figure out just the right title.
Yeah, yes, it's not a catchy one.
It's not catchy. It's not catchy.
Oh, no, it's a serious one. It's a
It is.
serious issue.
For some of us, it makes our hearts, I mean, not the actual thing, but to see it, it's great.
Yeah, I know.
Great. All right. Well, thank you to Andrew, who's joining me for this presentation this morning as well. And good morning, Secretary and members of the board. The purpose of this presentation is to give an overview of an issue wherein Massachusetts residents who are searching for health coverage, including those looking specifically for Health Connector coverage, may be marketed and sold a product that does not meet state standards or consumer needs. This dynamic intersects with the Health Connector's mission of trying to connect residents in need of coverage with vetted, high quality, comprehensive coverage that will be there for them. Non-compliant plans can harm the health and financial well-being of residents, and their presence can erode the stability and health of our health insurance risk pool. In recent years, Health Connector staff have observed an uptick of this kind of practice and have heard directly from residents who've been ensnared in these kinds of products, often only realizing it after they've gotten sick or had a medical event, and the product won't pay their claims. Sometimes sales agents or websites will advertise their offerings in a way that appears explicitly designed to mimic the Health Connector or the Affordable Care Act by claiming to sell Obamacare plans or ACA plans. This is also an issue of concern, of course, to the Division of Insurance and the Attorney General's office, as well as federal partners like CMS, as this is not a problem that is unique to Massachusetts. Today, we'll walk through what these products are and the tools we have, imperfect as they may be, that we've been using to try to deal with this problem and some proposed next steps. The issue of non-compliant plans is complex because there can be many different types of health products marketed that don't meet state and federal standards like required essential health benefits, like maternity coverage, hospitalization, et cetera, and other consumer protections like community rating. These plans can and do leave consumers exposed, but they may share different features. For example, there can be outright scams where individuals may be cold called and told about an attractive sounding coverage option, and they give their personal and financial information over the phone and are never enrolled in any kind of product or arrangement. There can be things like sharing arrangements or healthcare sharing ministries, which may or may not have a religious affiliation and are not insurance, but collect contributions from members and pay some claims, but are not subject to any benefits or consumer protection rules like licensed insurance. The specific characteristics of these products may differ, but they tend to share a common trait, which is they seek to be lower cost and attractive by not complying with benefits and rating rules that licensed ACA compliant coverage is subject to. And many individuals aren't able to tell when they're being marketed something that sits outside of the true insurance market and therefore doesn't have the same consumer protections. Many of the Massachusetts individuals that enroll in these plans are in fact searching online for Health Connector or other ACA compliant coverage, but end up being misled and sold something very different. In fact, this week there was an NPR story about people searching for ACA coverage online who end up surprised to find themselves in a sharing arrangement. And I linked to that story at the bottom of the slide. Among the many reasons we're seeking to better address this problem in the health coverage market, staff have noted the significant health equity dimensions of this issue. While there is limited data on who ends up purchasing and enrolling in non-compliant plans, based on the market behavior we observe and anecdotal evidence, it appears that many of the individuals that are marketed and sold these products are lower income and would actually qualify for free or low cost coverage through the Health Connector. That may mean that more communities of color or non-English speakers are ending up in these products without the sound health and financial protections they're entitled to. Many of the most significant health equity protections ensconced in state and federal requirements are those that are stripped out of these non-compliant offerings, making these products an even bigger issue in the aggregate to women, older residents, and communities of color who may have disproportionate greater healthcare or service needs. I will now hand it over to Andrew to give us a quick case study of one such recent instance that was addressed in a case brought by our Attorney General.
Thanks, Audrey, and good morning, everyone. So as Audrey mentioned, I'll be presenting a case study of predatory insurance practices revealed through a recent ruling by a Massachusetts judge on a case brought by our Attorney General. The case, the Commonwealth versus the Mega Life and Health Insurance Company, it actually stemmed from a case that originated back in 2006. That 2006 case at the time resulted in a consent judgment in 2009 prohibiting the companies at issue from engaging in certain practices, which include false and deceptive advertising related to the sale of insurance. In December of 2020, the Attorney General filed suit alleging violation of that consent judgment because the companies were engaged in various kinds of deceptive insurance-related sales schemes. And this past April, a Massachusetts judge agreed with those allegations and found that the companies had violated the consent judgment. And they did that by engaging in several practices, which I'll just summarize. You can also follow on the slide too. So these included falsely representing the services of their agents as free, despite the fact that the agents were repeatedly charging enrollees for those services. They misrepresented that sales agents were impartial and unbiased advisors representing all Massachusetts insurers. In reality, these agents were trained and incentivized to aggressively sell the defendant insurers' products and did not sell other forms of supplemental health insurance from all or even most of the other carriers licensed to do so in Massachusetts. They advertised and sold supplemental specified disease insurance as a substitute for major medical coverage. They advertised and sold short-term coverage without making necessary disclosures of exceptions and limitations to those policies. And they also sold short-term health insurance that did not cover comprehensive benefits, but stated that enrollees could see, quote, any doctor, which was very false. And they sold healthcare sharing ministry memberships, and they did that using insurance terms like premium, co-pays, carriers, even though those programs are not health insurance. So as you can see from this case, we know that we have a great and strong regulatory framework regulating the sale of insurance in Massachusetts, but bad actors are still very intent on selling their plans and using illegal means to do so here in the Commonwealth.
Thanks, Andrew. So now that we've just talked a bit about what these entities are.
Why don't we just pause? Let me just see.
Sure.
Nancy, anybody, comments, questions?
At some point, I'd love to hear what we do to the brokers or agents who push these two, and if there's been enforcement, if there's more we could take, steps we could take, and be particularly interested in Mark's thoughts about that too.
Yeah, I'm happy to jump in on that because that tends to be much more in the purview of the Division of Insurance as the licensor of producers and brokers. So we have a pretty robust enforcement, system. I think one thing that's difficult for us is that it's hard for us to practically identify these actors because they're commonly unlicensed by any state. But when we do find producers that are licensed by the state, our Special Investigations Unit provides a full investigation. It's referred to our enforcement attorneys, and we are then, when we take different sorts of enforcement action against them as well. But sometimes it's a little bit of, it's not necessarily a panacea because some of these websites maybe don't use any agents or producers, things like that. So it can be a little complicated. But just wanted to jump in on that we do work on that. And we also do work with the AG's office on these sorts of matters as well. And some of the health markets case that Andrew mentioned was something that the DOI had worked on as well. And we continue to work on in different ways.
Yeah, thanks, Martha. This is, although the form of the plans that get sold sometimes changes over the decades, this is a problem that's existed for a very, very long time.
Long time. All right, Audrey.
Okay. So now that we've talked a bit about these entities and how they interfere with the Health Connectors mission, we wanted to briefly highlight a few of the tools we have to help support people making their way to legitimate coverage and avoid non-compliant plans. So as the board knows, the connector sets the standards for the state's individual mandate in terms of what kinds of coverage can satisfy the mandate's requirements, which we call minimum credible coverage, or MCC, as you know. Some aspects of MCC may help disincentivize the sale of non-compliant plans because the state explicitly requires certain benefits to be covered, for example, As the board will recall, a few years ago, we even revised our MCC regulations to be more stringent regarding what kinds of sharing arrangements could be used to satisfy the mandate, and newly required reporting to the Health Connector about their presence and offerings in the Commonwealth, making Massachusetts the first state in the country to collect data and reporting from these entities. However, MCC does remain an imperfect tool for this problem, as MCC doesn't speak to rating practices like the ability to deny coverage to someone with a pre-existing condition. And further, the penalty for deviating from MCC standards is on the individual. The entity marketing non-compliant coverage is not penalized or necessarily deterred. The Health Connector has also taken steps to try to raise public awareness about how important it is for consumers, especially those shopping for their own coverage online, to be on the lookout for non-compliant coverage and know what to look for to ensure they're enrolling in something legitimate. We've worked with the Division of Insurance and the Attorney General's Office on advisories of this sort over the last few years, and are releasing this new advisory displayed here in the coming days, which has new and updated information on the latest dynamics we are seeing. And this advisory includes information specifically on websites that may mislead consumers and guidance for consumers to make sure they're purchasing legitimate coverage from a verified source, like the Health Connector or a DOI licensed carrier. In addition to specific consumer warnings and alerts, the connector can also play a key role in counter-programming against these kinds of non-compliant offerings through its own robust outreach and marketing efforts. As we know, if residents don't hear from or about the Health Connector or how to find it, they may be more likely to fall into the confusion and misleading messages they may hear online or through other channels. This is one of the reasons the connector continues to invest in extensive outreach and public awareness raising on a year-round basis, as there do remain residents who do not know where to look for trustworthy health coverage, and so can be vulnerable to misleading sales pitches. I'll now hand it back to Andrew to talk through a few enforcement tools the Health Connector has been able to tap into in this space.
Thank you, Audrey. So I'll be talking about a couple tools on this slide and on the next slide that we've been able to use, specifically addressing deceptive internet advertising, and also just highlight some of the limitations of these tools as well. So starting here with our trademark enforcement, the Health Connector owns trademarks on our name and on our logo, and Google and Bing each provide tools to trademark owners to report the unauthorized use of trademarks in paid advertising. So from our experience, when we saw our trademark appearing in a paid ad, it was almost always linking to an illegitimate website. And as far as we could tell, the purpose was of that site was to solicit contact information from people who were looking for health insurance, and then have that information wind up in the hands of some shady, likely out-of-state unlicensed broker, who would then call that person repeatedly in an attempt to sell them coverage from companies not licensed to sell coverage in Massachusetts, or otherwise sell them coverage that was not comprehensive. So having these tools is very useful in reducing the prevalence of ads that trade on the Health Connector's brand in order to mislead consumers and direct them away from the Health Connector's products. And through the use of these tools, we've actually virtually eliminated the infringing use of our trademarks in paid advertising on Google and Bing. So that's really great news. I'm really proud of the work we've done there. But as I mentioned, there are some limitations here. First, not all misleading ads use the Health Connector's trademarks. So this reporting tool doesn't really get at those ads, and you can continue to find paid advertising that links to these exact same sites, and they just don't use the Health Connector's trademark, and so we're not able to report them through this tool. And then the other thing is that if our name appeared in organic search results, that is not a paid ad, and merely having the Health Connector's name on a website is not necessarily a violation of any of Google or Bing's policies. And to the degree that we believe that they may be infringing on our trademark, it's really very difficult in our experience to enforce our trademark rights against entities like this. It's whack-a-mole, they're very shady. They're hard to find the site owner to even deliver a cease and desist letter to, and assuming you did get a site taken down, they just pop right back up under a different name. And so we continue to need to work on our trademark enforcement, as a tool, but it does have its limitations. And I'll just note that the connector really has been a leader actually in this space. We participate quarterly in program integrity meetings with other state-based marketplaces facilitated by CMS. And we have presented there on these tools and shared our knowledge and experience with other state-based marketplaces so that they too can report ads that may infringe trademarks that they have. Next slide, Audrey. So the other tool relates to a relatively new policy from Google and Bing. This one was rolled out in 2020. And these, again, aim at paid ads. So we're not talking about search results, but it's a different policy related to paid ads. Specifically, these policies prohibit the paid advertising for the sale of services that are otherwise provided by the government. And this includes ACA marketplaces, of course, like the Health Connector. So the nice thing about these policies, the scope is broader than just trademark. You're not just focusing on, some very specific sort of magic words to hook you into the prohibition. So more infringing ads can be reported and taken down. However, there are similar limitations here to the trademark enforcement tools. They rely on self-service. They rely on us to identify or other actors to identify ads that are in violation of the policy and report them. And it only applies to ads. So to the degree, again, there are organic search results that may be misleading, these policies would not prohibit those on Google or on Bing. So, another important and effective tool, one that we've availed ourselves of, and again, other state-based marketplaces we understand are also, monitoring for this, including, I should mention the FFM as well. But these are tools with some limitations.
Thank you, Andrew. So another dimension of this problem the connector is mindful of is it can be sometimes difficult for residents using online search engines who are searching for the connector to find their way to our correct URL. People Googling the connector can, for example, as Andrew noted, end up with a number of different search engine results, diverting them to various other websites that may look like the Health Connector or another legitimate source of coverage, and the connector's actual webpage may be the 4th or 5th listed result. The connector's IT and communication teams are currently developing a project plan that will allow us to clean up and modernize the underlying web technology that drives search engine results and address some of the issues that are leading to the Health Connector's URL being sometimes difficult to find via web search. So despite our best efforts with these tools that we've just touched on, unfortunately, we do know that many residents will get ensnared in non-compliant coverage. And one of the ways the connector has tried to help once we're made aware of such a situation is to work to help get affected residents into comprehensive health coverage. We've done this several times over the last few years by establishing targeted special enrollment periods for affected residents so they can get into coverage even if it's closed enrollment. We did this most recently with residents who had been enrolled in a sharing arrangement called Salvesen that was shut down by the DOI earlier this year. And we worked closely with Martha and her team at the DOI to make sure these individuals knew where to turn for real coverage and that we would allow them to enroll even outside of open enrollment. So we will continue to leverage.
Audrey, can I ask a question? The 3 that you listed, were they also operating in other states? I mean, it seems to me this is, it's obviously really a multi-state issue.
Those 3, yes, Simple Health, Aliera, and Salvesen. And I welcome any thoughts from Martha, but they were all in other states as well.
Yeah. Salvesen was operating unlicensed with the headquarters in Texas.
Yeah, they're always in Texas. Well, no, I mean, I think the reasons why they set up there because the regulatory structure, at least it used to be.
Yeah, but I will say we did have good conversations with Texas on Salvesen. They were really helpful on some things. So we definitely have a lot of interstate coordination, especially through NAIC on these sorts of matters as well. So we're always actively talking with other states to make sure we're aware of who's seeing what in this area, especially.
Thanks.
Yep.
So just to wrap up, we will, of course, continue to leverage the tools we do have at our disposal and try to work to develop additional strategies to make sure we're fulfilling our mission of connecting Massachusetts residents who need health coverage with the kind of coverage we know our residents deserve and meet state standards. And we'll continue to work closely with Martha and her colleagues at the DOI and the AG's office and CMS and others who are attuned to these issues as well. We're also going to be looking to other states who may have additional tactics and strategies for addressing the presence of these kinds of entities and their practices. We'll continue to keep the board posted on our ongoing work in this space, and we of course welcome any questions.
Great work on an awful topic.
Yeah. Is the federal government, so you mentioned meeting with the CMS on a regular basis with other exchanges. Is there any other federal enforcement work going on? You know, understanding that insurance is regulated primarily at the state level. But Martha, you mentioned NAIC, but is there any action going on by any federal agencies that might be able to exert any kind of jurisdiction on this?
Sorry, Audrey, I don't know if you have.
Oh, no, you go ahead, Martha.
I'd say most of our, I mean, as you note, that insurance is mostly a state-based regulated industry. So that's why the work with NAIC is so important, because we're able to coordinate with other states on this. I think we've had a couple conversations with CMS on these matters, but especially when it comes to somebody representing themselves as an insurer, you know, it's been at least my experience has been we've been working more with other states and with the NAIC on this issue. I don't know, Audrey, if you've had some other interactions.
No, I think the only thing I would add, and this is not the same as like unlicensed or like true scam things, but I would say, you know, we're aware that the Biden administration is contemplating tightening rules around short-term limited duration plans and some of those other kinds of plans that are not subject to the same ACA requirements. So again, one of the many flavors of these kinds of products, but we're aware that they are exploring kind of regulatory tightening around some of those rules that under the last administration had been loosened.
Yeah, there have been issues in the past which occasionally the FTC has gotten involved in. I didn't know if this was on their radar screen at all.
Yeah, the FTC was actually who brought Simple Health down. So that was a space that they were involved in a couple years back. Anything else?
Anybody else? All right, actually, that's probably a good segue into the federal policy update.
Okay. And Marissa's going to kick us off here.
Yes. So today, Audrey and I will walk through some federal policy updates on both the administrative and congressional fronts. I'll walk through two recent regulations, a proposed rule related to the so-called family glitch, and the final 2023 notice of benefit and payment parameters. And then Audrey will walk through the uncertain status of the extension to enhanced premium tax credits made available by the American Rescue Plan in 2021. So slide 4. So first, we're following a proposed rule by the Treasury Department and IRS that came out in April that would fix what's known as the family glitch and allow more households to access advanced premium tax credits for 2023. Under the ACA, individuals may not receive APTCs if they have access to affordable coverage through an employer. However, until now, only the premiums for a self-only plan for the employee were used to determine affordability, even if the household was larger and needed a family plan that was much more expensive. This rule would reinterpret the ACA to use the self-only premium when considering whether the employee has access to affordable coverage and the family premium to determine whether other members of the household do. Next slide. So we're working with the HICS team to be able to go live with this change as soon as the final rule is issued. Once that technical update goes live, people will be able to report the family premium for an employer-sponsored plan and have their 2023 eligibility reassessed under the new rules. In conjunction with this technical update, we're also considering the best way to alert members and applicants to this change and encourage those we think might be impacted to return and check their eligibility again. It's a bit hard to estimate how many individuals may be positively impacted by this proposed change, but an Urban Institute analysis suggested about 44,000 Massachusetts residents could benefit. Next slide. And secondly, we recently reviewed the final notice of benefit and payment parameters for 2023. This is an annual regulation that touches on a variety of exchange and commercial market policies more broadly. This year, we were closely following a few items of interest. One was a proposal that state exchanges adopt healthcare.gov's approach to partial month premium and APTC allocation that would have required quite a bit of work for us to implement. And a second was a suite of rules to implement audits of exchange processes to determine if improper APTC payments were made. Neither of those proposals was finalized at this time, but we'll monitor future rulemaking in these spaces in case they come back. And a third provision that was finalized and did impact our work was a narrowing of the actuarial value ranges associated with each metallic coverage tier. So for the last several years, we've offered a low gold plan at the bottom of the allowable range at 76% AV. But based on this regulatory change, we amended our seal of approval documents and instructed carriers to adjust their low gold offerings to fall within the allowed range that now starts at 78% AV. Let me pause there for questions before I turn it back to Audrey.
Other than hallelujah on
Yeah.
the family glitch. How many years have we, I mean, I'm sorry. I don't mean to be,
We were excited to see it.
How many years? Like 12.
Yep, that's right. I'm sorry, I'm not laughing. It's long overdue.
Yes.
It's good stuff. Any questions, comments? And I haven't heard anything, around the technology, any issues with the technology fix. So,
Yeah, we're ready.
yeah, no.
All right.
I think I still have PTSD from 2015. Some of you have it from earlier than that around, when we talk about fixing the Hicks, I'm like, oh, another change. But I think we're in good shape. All right. American Rescue Plan premiums.
Yes. Okay. So we also wanted to touch on an important area of federal policy that is currently unsettled and has significant implications for Health Connector members, which is whether or not the American Rescue Plan premium subsidy expansions that have been in effect for 2021 and 2022 will be further extended beyond this calendar year, or whether they will go away at the end of December as they are currently slated to. The extension of the ARP subsidies beyond 2022 was included in the Build Back Better budget reconciliation bill that passed the U.S. House last fall, but did not make it through the Senate. We understand the congressional leadership are considering options for a budget reconciliation bill this year, which may or may not include ARP subsidy extensions. At the moment, no firm legislative vehicle or strategy has yet emerged. In terms of impact as a top line, if these premium expansions do expire, we would expect roughly 200,000 residents currently enrolled in connector coverage to see premium increases beyond underlying rate growth as we head from 2022 to 2023. We're of course concerned about the affordability impacts of such a cliff on the population we currently cover, as well as individuals that will eventually migrate from mass health coverage to eligibility for Health Connector coverage at the end of the PHE, as Marissa and Monica described. Just as the quickest of backgrounds, the American Rescue Plan included an expansion of ACA premium tax credits, or APTC, that lower the cost of health coverage for people enrolled in marketplaces like the Health Connector. It did this by making people who already qualified for APTC qualify for even more, further lowering their premiums. It also did this by lifting the cap on income for who could qualify for APTC and newly allowed moderate income individuals over 400% of the federal poverty level to qualify for APTC if the benchmark plan available to them costs more than 8.5% of household income. So in short, more people qualified for APTC and the APTC itself was more generous. So what impact have these expanded premium tax credits had here in Massachusetts? The ARP has brought roughly 200 million new federal dollars into the state to help lower healthcare costs, both across connector care and non-connector care populations on the marketplace. It's also driven strong new enrollment and retention of existing members on the Health Connector, consistent with national trends around strong marketplace enrollment after the implementation of ARP subsidies. And in terms of impact, we also wanted to spotlight a population that has particularly benefited from the ARP subsidies, which is older adults in the individual market. Because of age rating, which allows older individuals who may be just nearing Medicare eligibility to be charged for the same health plan twice the amount of what a younger individual is charged, more older Massachusetts residents qualify for even greater ARP subsidies. So some examples in the table on the bottom right give you a sense of the scope of these savings for these middle income older residents and the material premium relief they've experienced over the course of 2021 and 2022 so far. The savings are particularly striking in very high cost regions of the state like the islands. Here are a few more data examples we wanted to lift up. And these examples reflect a range of different regions around the state, but look at the approximately average age of a Health Connector member, which is about 43. While these savings amounts aren't quite as stark as the ones we saw in the previous slide for older adults, they remain material savings that we know affected members' health coverage access and financial well-being in very real ways. While the data tell a powerful story about the savings and premium relief residents have felt as a result of the American Rescue Plan, members' input in their own words is even more impactful, with majorities of surveyed members reporting the premium subsidies as very or extremely helpful. These quotes represent just a subset of the many comments we received from members when these premium savings were first implemented, underscoring the on-the-ground financial relief and health coverage security that residents have gained. The flip side of the relief of the ARP subsidies has had is, of course, the impact of them possibly going away. We anticipate that around 200,000 enrollees would see reduced or eliminated financial assistance, and so would experience premium increases on top of whatever medical trend or regular rate increases will bring as we head from 2022 to 2023. These increases shake out differently for different populations. A connector care enrollee might expect to pay $24 more a month, again, on top of trend, whereas a middle income resident who newly qualified for APTC would pay about $143 more per month on top of trend. Middle income members between 55 and 64 years of age would pay anywhere from $200 to $600 more per month, again, as a result of age rating dynamics. This will make coverage less affordable for the individuals we already serve and make coverage harder to afford for residents who need to newly come into connector coverage. And of course, we worry about the compounding effects of reduced affordability at a time when many households are experiencing increases in costs of other household essentials. So on both of these federal policy fronts we've discussed today, both the future of the American Rescue Plan subsidies as well as federal rulemaking, we will continue to keep the board posted, of course. Since preparations for open enrollment begin in the summer, our hope is we have resolution on the future extension of the ARP subsidies in the next 2 months or so in order to avoid consumer and system impacts. On the rulemaking front, we will keep the board posted on the finalization of the family glitch rule, and we stand ready to implement and work to ensure its benefits reach the Massachusetts residents newly eligible for the help that it will provide. So we'll close there, and of course, happy to take any questions.
Comments, questions, anybody? Nancy?
Audrey, do we have any data that would, one could imagine that with that amount of premium relief at the higher age groups in particular, that the percentage of people who had coverage might have gone up. Do we have any data at the state level that would shed light on that?
I welcome any thoughts from Marissa. I mean, I know that recent CHIA enrollment data is showing that more people in Massachusetts are covered than ever, and we've of course seen growth in particular populations. Yeah. I'd have to check on the age bands to see if that's true with respect to older individuals sort of newly joining coverage, or whether it's people who are already covered just getting new relief. But we can go back to that in our own data and also look at CHIA data as well.
Yeah, I'd just be curious. I search for someone, I saw this was, but I sometimes can't find things that CHIA has. So I would love any insights you all have on that.
Absolutely.
We did see during open enrollment that our new members were a little bit older than they have been in prior years. And so that may be a reflection of those increased premium subsidies for that population.
Yeah, that makes sense too. Yeah, great. Anything you could share would be great.
Matt? Morning, Matt.
Good morning. Thank you, Madam Secretary. I'm going to try to preempt my colleagues Rena and Mark with my comment here, which is the potential expiration of these subsidy programs, I think continues to raise the urgency of the Commonwealth really doing something meaningful and impactful around the underlying cost of care, right? These subsidy programs, they will, depending on the kind of broader political climate, they will wax and wane. And I know, I'm sure my colleagues at the DOI and at the connector are seeing with rising levels of concern what the coming years look like, what the coming months and years look like as it relates to healthcare costs. So, the governor has filed a bill to really get at a lot of the short-term and long-term trends to get the system back on a sustainable path. The HPC is doing some really excellent work in this space, but it really does bring to mind for me again the urgency for action on underlying drivers. Thanks.
Thank you. Yep. Anybody else? All right. Onto the business, the business side of our shop here. We have a contract that we need to consider. Who's teeing that up?
We've got Elliot Gorman. Elliot?
There he is. Hello, Elliot.
Morning. Let me share my screen.
You need to fix your camera. We're losing the top of your head.
I'm sorry. Here we go. Can everybody see my screen?
Yep.
Excellent. So good morning, Madam Secretary and members of the board. I'm Elliot Gorman, and we'll be providing some background on a contract renewal, which we will be putting forth for a vote. The Health Connector is requesting approval through a vote to renew a work order with Smartronix for AWS cloud-based services. Smartronix is a reseller of cloud infrastructure and platform as services through the state's contract RFR 1621. The Health Connector has been utilizing Smartronix for these services since 2017 for both enterprise technology services as well as member-facing services. AWS offers a flexible and scalable suite of cloud-based technology services that align well with the Health Connector's strategic business goals as well as operational needs. The scope and utilization of AWS cloud services have significantly expanded with the Health Connector over time, resulting in increased costs year over year. Oops, go back. Some of the cloud-based services leveraged by the Health Connector include enterprise data storage, database computing, reporting and analytics, and a virtualized desktop environment. We also host several member-facing services, such as our Get an Estimate tool and tax-related calculators, hardship appeals and ombudsman requests, and small group ConnectWell application. State blanket RFR 1621 provides infrastructure and platform as a service services. By leveraging RFR 1621, the Health Connector benefits by relying on a vendor procured through a statewide procurement process, including all of the strong contractual protections that come along with the state contract. Through the statewide procurement process, Smartronix was awarded RFR 1621, and as a reseller of AWS services, offers a 12% discount off list costs for all Massachusetts agencies. The cost of this work order would be in an amount not to exceed $337,920 billed monthly. Typical monthly cost would be $32,000 per month or list costs. However, RFR 1621 provides a discounted amount of $28,160 per month. With that, I'd open it up to any questions.
Any questions? The Commonwealth is obviously moving everything to the cloud. The connector is benefiting in part from the state's contract and the negotiated rates we have. That's the non-technical explanation of this. And all my technical friends will just like all cringe now, but that's basically, this is moving everything to the cloud. And the architect can just like, what did she just say? But anyway. All right, so we have a vote May I have is there a motion?
So moved.
And I think
Second.
Nancy, second is Matt. Is there any further discussion on the motion before you? If not, can we do the roll call, please?
Okay, Martha,
Yes.
Michael,
Yes.
Cassandra,
Yes.
Secretary,
Yes.
Nancy,
Yes.
Matt,
Yes.
Rena.
Yes.
Thank you, everyone.
Okay, thank you. Motion carries. Thank you for that. All right. Is there any further business before the board this morning? I do want to thank all the Connector staff for always the excellent work that they do and supporting Lewis's league. So, and for the strong work with Mass Health to ensure consumer protection. All right. Well, if there is no further business before the board, then I'd ask for a motion to adjourn.
So moved.
Right, you think you want to stay, Matt? Is there a second, please?
I second.
Thank you. All right.
I'd love to stay further, but yes.
Yeah, no, it's good stuff. All right. So we have I think we need to do the roll call.
Okay. Martha,
Yes.
Michael,
Yes.
Cassandra,
Yes.
Secretary,
Yes.
Nancy,
Yes.
Matt,
Yes.
Rena.
Yes.
Thank you, everyone.
All right, everyone. Thank you so much. Be well, take care, and we will see you at the next meeting. All right.
Thank you.
Thank you all.
Thanks, everyone.